I'd like to start with a land acknowledgement. Acknowledge that we live, work, and play on the traditional territories of the Blackfoot Confederacy, the Tsuut'ina, the Stoney Nakoda Nations, the Métis Nation, and all people who make their homes in the Treaty 7 region of Southern Alberta. We here at the Calgary Adapted Hub, powered by Jumpstart, are very excited to have Dr. Kathleen Martin Ginis here today. Dr. Kathleen Martin Ginis holds the Reichwald Family Chair in Preventive Medicine at the University of British Columbia's Southern Medical Program and is the director of the Centre for Chronic Disease Prevention and Management. She's also a UBC Distinguished University Scholar Professor in the Department of Medicine, Professor in the School of Health and Exercise Sciences, and an ICORD Principal Investigator. Dr. Martin Ginis has received over $12 million in research funding and has published over 350 peer-reviewed articles. Her research program focuses on physical activity behavior change and the psychosocial consequences of physical activity participation, particularly among people living with spinal cord injury and other physical disabilities. Kathleen, again, thank you so much for being here, and I'll let you take it away with your talk for today.
Thank you, Alyssa. Let me just get set up here. Everyone seeing my full screen?
Yeah, you're good.
Terrific, thank you. Well, good afternoon, everyone. It's such a pleasure to be joining you on this webinar. I am completely in awe of what the Calgary Adaptive Hub and Jumpstart are doing for children with disabilities and for adaptive sport and recreation. And it's a real honor to be here today. So again, thank you for the invitation. I want to begin by acknowledging that I live and I work in Kelowna, British Columbia, and my home and my office is located on the traditional, ancestral, and unceded territory of the Silks Okanagan Nation. I'm presently sitting here inside my lab at the University of British Columbia, Okanagan, and I live here. And every day on my commute, I feel deep gratitude to the Indigenous caretakers of this beautiful land. A few disclosures. And let's get started. So just to give you a bit of an overview, today I've divided this talk into two parts. The first is about improving physical activity participation rates. I'll talk about what the research shows about how to do this, and then dig into how to design and implement interventions to increase the numbers of people with disabilities who participate in physical activity and the amount that they participate. Then I'll shift gears and talk about improving physical activity participation experiences, particularly what is quality participation for people with disabilities and how to create quality participation experiences. So I don't think I'll need to convince many people on this webinar of the tremendous physical activity benefits for people with disabilities. Over the past 20 years, there's been a substantial generation of evidence that speaks to the physical, the psychological, the social, and even the economic benefits of physical activity for children, youth, and adults with disabilities. And yet we still see that physical activity participation rates for people with disabilities are remarkably low. I should mention, we see these data often, but we have really horrible data on physical activity participation worldwide for people with disabilities. The data on the left come from a study of 15 European countries, and the measure that was used in that study was just a simple binary outcome of whether children were or were not meeting the WHO physical activity guidelines. And so while the differences look subtle between children with and without disabilities, I think most of us know that the differences are far more profound than that. And that really speaks to the need for better physical activity data collection worldwide. So the differences in physical activity participation rates for people with and without disabilities is largely a reflection of the tremendous physical activity barriers that are experienced by persons with disabilities. There have been quite literally hundreds of studies conducted that have documented the participation barriers experienced by people with disabilities. In 2016, we published a meta review of 22 review articles that looked at barriers, facilitators, and other factors related to physical activity for kids and adults with disability. So from these 22 review articles, we extracted over 200 different barriers and facilitators to physical activity. We took this information, we took these factors, and we organized them into themes. From there, we took the themes and we situated them in a social ecological model in order to show which barriers can be addressed by focusing on factors at the individual level and in their social environment versus barriers that are going to need to be addressed at a broader systems level. That is in the community, at the institutional and the policy levels. You can see at every single level, there are substantive barriers. We also coded the barriers according to whether they can be addressed by the healthcare sector, the recreation sector, or whether there was an overlap between the two. And this was in response to a call that Jim Brimmer has made for greater synergies and greater coordination between the healthcare and the recreation sectors in terms of promoting physical activity for people with disabilities. When we look at the barriers in this way, I think it's helpful for telling us what barriers to target in physical activity enhancing interventions and in which sector or which context we need to target those barriers. I think it's also important to note that so little research has been conducted that has looked at barriers outside of the interpersonal or the interpersonal levels. From there, we started thinking about community-based interventions to target those barriers. So at this point, I wanted to take a look at what that research tells us in terms of the effectiveness of physical activity enhancing interventions for children and adults with disabilities. So I'm very pleased to share that the Lancet Physical Activity series will be published for the third this July. And for the first time, it will include a paper that focuses specifically on physical activity and disability. As part of that paper, we conducted a meta review of meta-analyses that tested the effects of physical activity enhancing interventions in children, youth, and adults with disabilities. We found a total of 9 meta-analyses, and I've shown these 9 meta-analyses on the y-axis of this graph, along with their effect sizes. Of these 9 meta-analyses, only 3 included studies that involved children with disabilities. All of these interventions targeted factors at the individual or at the social levels, such as physical function, motivation, self-efficacy, and social support. How did they do? Well, looking at the meta-analyses involving people with physical disabilities, overall, the median effect size was 0.64, and we consider this to be in the medium to large range in terms of the magnitude of the effect size. With regards to intellectual disabilities, we found only 2 meta-analyses that involve people with intellectual disabilities, and these effect sizes were not nearly as strong. They were in the small to medium range. As I mentioned, there has been very little research looking at interventions at the institutional, community, and policy level. So there were no meta-analyses of these studies because there are so few. But I wanted to give you just a couple examples of interventions that have been attempted at these levels, just to give you an idea as to the things that people are trying and that they're working on. So at the institutional and community levels, we've seen approaches such as formulating guidelines for constructing accessible built environments, the development of inclusivity training programs for phys ed teachers, and the establishment of programs that loan equipment for adapted physical activities. At the policy level, we've seen policies to fund sports programs and equipment, to ensure that built environments are accessible, and to provide accessible transportation. But as I mentioned, with just a couple of exceptions, there's been essentially no evaluation of the effectiveness of these policies, so it's difficult to speak to their effectiveness at this point. So what can we conclude from the available evidence? I think a big takeaway, particularly with regards to the studies involving children, is that therapeutic interventions do not increase physical activity. We saw in the literature several interventions where the focus was on trying to improve the child's gait, for example, or their mobility. Those interventions did not increase overall physical activity in children. We did see that the largest effects were for interventions that were based on some type of theories of behavior change, theories of human motivation, and also interventions that focused specifically on incorporating behavior change techniques. And I'll talk more about these in a few slides. At this point, we know very little about the effectiveness of interventions for people with sensory or intellectual disabilities, for children with disabilities, or for interventions that target community, institutional, or policy level factors. So I'd like to dig a bit deeper now into the research evidence on what we do know about designing and implementing physical activity enhancing interventions for persons with disabilities. So the first question is, what does the research tell us should be included in physical activity enhancing interventions for these populations? A few years ago, we reviewed and we synthesized qualitative studies that reported on the experiences of people with disabilities who took part in some kind of intervention that was designed to increase their physical activity participation. And our synthesis revealed three key themes. Participants said that effective interventions provided them with evidence-based information, both on physical activity and also how to self-manage their particular disability or health condition within the context of being more physically active. And I think that physical activity guidelines can play an important role in addressing this informational need, particularly physical activity guidelines that are specifically written for people with disabilities. I hear all the time from adults with disabilities and parents of kids with disabilities that they're quite anxious about initiating a physical activity program or trying a new sport or trying a new exercise. They don't know how to get started or what types or amounts of activity are appropriate given their disability or their condition. Furthermore, the people who work in gyms and fitness centers and rec centers, they often don't know how to support a person with disability to be physically active, and they end up turning people away because they don't have this basic information on how to support a person with a disability in achieving their exercise goals. Physical activity guidelines that specifically target and are tailored to people with disabilities can help address some of these knowledge barriers. Now, recently, in their new 2020 physical activity guidelines, the World Health Organization extended their guidelines for the general population to include people with disabilities. So in other words, the WHO said that the guidelines for the general population of children, youth, and adults can also apply to children, youth, and adults with disabilities. For instance, for adults, the WHO recommends at least 150 to 300 minutes per week of moderate to vigorous intensity aerobic physical activity and strength training 2 days per week. So while I'm really pleased that the WHO is thinking about people with disabilities, this is something that I've been vocally critical of, is this extension of the WHO guidelines to people with disabilities. It's really important to note that the evidence underpinning the WHO guidelines was based almost entirely on evidence from the general population, not from people with disabilities. So the guidelines don't take into account physiological differences in exercise responses of people with certain types of impairments, or contextual differences in physical activity barriers and opportunities for people with disabilities. In fact, the WHO is recommending 150, 300 minutes per week of aerobic activity for people with disabilities, but there are no studies involving people with disabilities that have actually looked at the long-term effects of following that guideline over the long term. So at this point, we really don't even know the safety of following that guideline for people with disabilities. Now, on the other hand, there is strong evidence that people with disabilities can achieve significant health and fitness benefits by performing physical activity well below the 150-minute per week threshold. So given this evidence, disability-specific physical activity guidelines have been developed for people with multiple sclerosis and for people with spinal cord injury, using research evidence specifically derived from studies involving those populations. And these guidelines recommend lower volumes of aerobic activity than what the WHO guidelines recommend. And I think that because these guidelines were formulated with people with disabilities and for people with disabilities, taking into consideration the needs, the preferences, and the values of those groups, that these guidelines have the potential to be, they're more realistic and more meaningful to the people with these conditions, and potentially more likely to be adopted and used. The second theme that emerged from our review was that people with disabilities said effective interventions provided them with training on specific behavioral strategies or techniques that they could use to help them initiate and maintain a physical activity regimen. A few years ago, Jasmine Ma and I published a meta-analysis of 24 randomized controlled trials of physical activity interventions for people with physical disabilities. And as part of that meta-analysis, we wanted to see which behavior change techniques were being used in the interventions, and more importantly, which ones were most effective for increasing physical activity in people with disabilities. Across the 24 trials, we found that 30 different behavior change techniques were used. We looked at the effects on physical activity behavior for studies that used a particular technique versus studies that did not use a particular technique. So on the left side, on the y-axis, I've got 5 techniques in particular that we looked at. And for each one, the top bar shows the mean and standard deviation for the effect size when that technique was used, and below was when it was not used. So we found that interventions that taught people how to self-monitor, that is to keep track of their physical activity, that provided people with feedback on how they were doing. So were they becoming more active or were they meeting their goals? That instructed people on how to be physically active with a disability, and taught people how to problem solve in order to overcome barriers, that these interventions produce significantly greater improvements in physical activity than interventions that did not use those techniques. Interestingly, studies that used a technique whereby other people monitored the participants' physical activity levels, but they didn't give them any feedback, in those studies, physical activity levels ended up being lower when they used that technique than in studies when they did not. So overall, I would highly encourage if you're developing an intervention, to incorporate self-monitoring, behavioral feedback, behavioral instruction, and problem solving, and really to shy away with the monitoring by others without feedback. We also noted that participants found effective interventions gave them social support, particularly from health and fitness professionals. And I think this third theme is nicely summed up by this quote. Having a person who can actually give recommendations on fitness activities with the knowledge of my condition is very helpful and not easy to come by in the gyms or anywhere else where people have any clue or can give advice. So the next question is, who should deliver physical activity enhancing interventions? Work in my lab and others has consistently shown that people with disabilities want to get their physical activity information from 2 groups of people. First of all, they want to get information from healthcare providers, and I use that term very liberally. Physiotherapists, family doctors, specialists, recreation therapists, OTs, nurses, these are all considered reliable sources of physical activity information and valued sources from the perspective of people with disabilities. The second group that people with disabilities want to get physical activity information from are their peers. Again, an incredibly valued source of physical activity information and interventions, as this quote describes. Other people who have done the activity and can tell you from a person that is disabled what it's like to do that activity and what it involves. I mean, I think that speaks volumes to somebody with an injury to hear that. It is helpful. So the next question is, how should activity enhancing interventions be developed? So in the past, I think there's been a long history of behavioral interventions being ineffective and often criticized for being developed using an approach that has been referred to as islagiat, or it seemed like a good idea at the time. In contrast Campbell and colleagues put forth a framework of steps for developing complex health interventions. And I think when we're talking about developing physical activity interventions for people with disabilities, we have to appreciate that that is a complex challenge. That is a complex health intervention. And I think that the Campbell et al. Framework applies very well to physical activity intervention design for these populations. Now, the design of theory-based behavior change interventions is a topic that could easily take up an entire webinar, in fact, an entire semester, I think, or several webinars. So with our limited time today, I'm going to direct you to Susan Mickey and colleagues' behavior change wheel, which conceptualizes behavior change is boiling down to really having a good understanding of people's capabilities, their opportunities, and their motivations for changing their behavior. Once you truly understand those three concepts, the idea is to align challenges around those capabilities, opportunities, motivations with appropriate theory and evidence-based behavior change strategies. So their book, shown on the left, is an excellent guide for developing interventions for all types of different behaviors. If you're looking for a resource specifically about physical activity behavior change, the most recent edition of our Psychology of Exercise book has 2 chapters written about the behavior change wheel by Dr. Heather Gainforth, who studied under Mickey. So that, I think, could also be a useful resource specifically for exercise behavior change. I'd like to give an example from my lab of how we use the behavior change wheel approach to co-develop and test the effects of a behavioral physical activity intervention and its effects on physical activity, psychosocial predictors, and fitness in individuals living with spinal cord injury. We use the Campbell et al. Framework to guide the development of the intervention, which is shown across the top. And we spent nearly 2 years just on designing and developing the intervention. We completed systematic reviews to fully understand those capabilities, opportunities, and motivations. We conducted interviews of people with spinal cord injury, surveys of physiotherapists, because we wanted the physiotherapists to deliver the intervention to people with spinal cord injury. And we brought these groups together for an expert panel consensus. Over the entire design process, we engaged over 300 end users in designing this intervention. We also spent a lot of time on choosing an appropriate measure of physical activity. And we largely did this just because physical activity measurement in people who use wheelchairs, perhaps especially people with spinal cord injury, it can be quite tricky. And to do this, we ran a study of 18 people with spinal cord injury to compare physical activity measurement using wrist-worn accelerometers versus a validated self-report measure of physical activity. So this is a bland Altman plot. And what this shows is for values below the line, this indicates people who self-reported more activity than what the accelerometer detected. And for those above the line, this indicates people who self-reported less physical activity than what the accelerometer detected. So this gives us a good opportunity just to see the relative over versus under reporting of physical activity relative to the accelerometer. And you'll see it's about even, that roughly equal numbers of people reported more versus less than what the accelerometer recorded. We found 2 categories of activities where people consistently self-reported more activity than the accelerometer recorded. So people over-reported the amount of time they spent doing daily chores, such as the dishes and vacuuming. They also over-reported intermittent activities. So sports such as tennis, rugby, they tended to report more time spent moving than what they actually did, and activities such as gardening. On the other hand, we found that the accelerometers were unable to detect strength training activities, such as using resistance bands or lifting weights, and they were also unable to detect wheeling up an incline. So just an interesting sidebar story. We conducted this study from ICORD, which is at the Blesson Spinal Cord Center at UBC in Vancouver. And this is a picture of the building from the outside, and those multicolored panels that you can see, that actually is the railing of a 200-meter ramp that winds its way from the first floor up to the third floor of the building. It's on a 5% incline. And while we were conducting this study, one of our participants was trying to raise funds by wheeling up the ramp 100 times. So he was in the study, he was wearing the accelerometer, and he totally met his goal. He made it up and down 100 times over the week, and the accelerometer did not capture even one of his climbs. So this led us to the recommendation that for wheelchair users, physical activity should be measured using both validated self-report measures and accelerometry. Either measure on its own is not going to give you as full a picture as possible of the physical activity profile of study participants. So coming back to the trial, with that development phase complete, we moved on to create a prototype. We called our intervention the PROACT SCI Toolkit. So this intervention, the manual is actually a 50-page manual, but I'm going to boil it down to our one-page cheat sheet, which really begins by the interventionist, i.e. a physiotherapist, getting an understanding of each individual's capabilities, opportunities, and motivations. Then moving on to teach about the SCI exercise guidelines. And then in step 3, creating an individualized, tailored intervention that provides information to the clients and behavior change techniques to help them overcome barriers to physical activity. That also links and refers them to resources to support them being active in their communities. And also providing a tailored exercise prescription, so they know exactly what exercises to do, for how long, what intensity, using what equipment, in order to meet the SCI exercise guidelines. And this intervention, it's developed, or it's designed to be an 8-week intervention, where the interventionist spends 1 hour with the participant the first week, and then over the next 8 weeks, they receive a 15-minute phone call every week for 8 weeks to deliver the intervention, adjust the behavior change techniques, and so on. We began by piloting the intervention with physiotherapists just to make sure it was feasible. And after that, we moved on to a randomized controlled trial. So this was a study involving 30 people, 30 adults with spinal cord injury. Half were randomly allocated to a waitlist control condition, and half were randomly allocated to our intervention condition. And once again, this was an 8-week intervention. So what did we find? The theoretical approach we used to design the intervention was Schwarzer's Health Action Approach Model, or HAPA model. So first we wanted to see whether some of the key psychosocial mechanisms that should drive behavior change, we wanted to make sure that our intervention did indeed change those. And we are very pleased to see that compared to the control group, the intervention group had significant improvements in their self-efficacy, that is their self-confidence to be physically active, their sense of social support for being physically active, and their ability to self-regulate, i.e. their ability to use behavior change techniques that would help keep them on track. With regards to physical activity and fitness, we found that by both our self-reported physical activity measure and our accelerometry measure, our intervention group had significant increases in physical activity relative to the control group. And they also had significant increases in VO2 peak relative to the control group. The increases in physical activity were sustained over a 6-month follow-up period. And I wanted to emphasize that this is the first behavioral intervention to show that we can significantly increase aerobic fitness in people with spinal cord injury using behavior change methods. So we were very pleased with the outcomes of this trial. The effect sizes are also the largest that have been seen in any group with a disability in a physical activity behavior change intervention. And we took some time to really sit back and think about what made this intervention so effective. And I think it really boils down to the fact that it was theory and evidence-based. We developed it in partnership with over 300 end users to make sure that it really met the needs, the values, and preferences of the users. And by doing that, we were able to ensure that the intervention was tailored and responsive to the varying exercise barriers, needs, and motives of our participants over the course of the 8 weeks. And I should mention that intervention is now being delivered at our provincial rehab hospital as part of a pilot project. And we're hopeful that we'll eventually be able to see reach right across Canada. So switching gears a little bit, when we start thinking about physical activity enhancing interventions, I think it's also important to acknowledge in our interventions that people with disabilities exercise for different reasons. So in this qualitative study by Tony Williams and colleagues, they found among people with different types of disabilities that many people did indeed endorse that exercise is medicine narrative, but there were also people who did not, that they actually found exercise was not medicine. They found it increased their pain. But also many people were exercising for different types of pleasure, enjoyment, satisfaction, socialization, and so on. And in thinking about the different reasons people have for being active, that brings us to the idea that people attach different meanings to their participation in sport and exercise, and that what constitutes full and effective participation for one person is not necessarily the same as what it means to another. But nonetheless, the right to full and effective participation, whatever that means for an individual, it's enshrined in the UN Convention on the Rights of Persons with Disabilities. So how do we capture those different individual conceptualizations of full and effective participation? And more importantly, how do we ensure that physical activity programs and opportunities are designed to provide these positive participation experiences? The traditional approach to thinking about participation has been to conceptualize it as simply whether a person is present and if they're performing certain activities or roles. So to use an exercise example, participation has typically been conceptualized as whether you show up at the gym and how many minutes you spend on exercise, or in a sports setting, whether you joined the team and how many goals you scored. Studies of people with disabilities, and even in talking to people with disabilities, it's very clear that simply showing up or simply doing an activity is not the same as full and effective participation. In fact, based on a review of the literature, we found that for people with disabilities, full and effective participation really boils down to having at least one of the following outcomes from the participation experiences: a sense of autonomy, that is having independence or choice or control over the activity, or a sense of belongingness, that is feeling included, a sense of being appropriately challenged or tested. Could be feeling engaged, that is being in the moment or focused, or feeling a sense of being absorbed or fascinated. Mastery is also an important experience for people to have full and effective participation, as is a sense of meaning and contributing toward obtaining a personal or socially meaningful goal. Understanding how these 6 positive experiences are created during participation, their implications, and the development, testing, and implementation of interventions to improve them is at the core of the Canadian Disability Participation Project. So the CDPP is an alliance of university, public, private, and government sector partners working together to enhance community participation among Canadians with physical disabilities. It's funded by a SSHRC partnership grant that we received, a 7-year grant we received in 2014. So this is just a schematic that shows our community partners and our general structure of the CDPP. And we focus on improving both the amount and the quality of participation in 3 domains: employment, mobility, and sport and exercise. When we started in 2014, originally our focus was only on people with physical disabilities, but over the 7 years, our work has extended to other types of disabilities, people with sensory and cognitive impairments, for example. The work I'll be sharing with you today comes specifically from the sport and exercise team, which is led by Dr. Amy Latimer-Chung from Queen's University and Jenny Davey from the Canadian Paralympic Committee. What Amy and her team have done is they've taken those 6 elements of quality participation and they've done extensive work to develop these into the Parasport Quality Participation Framework. Their development of this framework has been scientifically rigorous. They've used community engaged methods and an evidence-based approach. It was originally developed from a synthesis of all the quantitative and qualitative research we could find on disability sport, looking at psychosocial experiences of participants. The principles of quality participation were drafted from that and refined in collaboration with dozens of athletes, coaches, and sport programmers before being consolidated into a framework. And I know this is a horrible slide. I put it in for the scientists just to direct you to the research that's underpinning the resources I'm about to share, but also for the non-scientists so that you can have confidence that the guidance and resources I'm about to share with you are deeply entrenched in both a scientific process and in scientific evidence. You know, ultimately what the framework entails is it identifies 25 different conditions, so evidence-based conditions or evidence-based strategies, things that can be done that foster autonomy, belongingness, challenge, engagement, mastery, and meaning. It also identifies the three domains where these things can be applied: the physical sport environment, the social environment, and in the design of activities. So in a nutshell, what the framework does is it explains that quality participation is achieved when athletes with a disability view their involvement in sport as satisfying and enjoyable, and when they experience outcomes that they consider important. So how do we achieve quality sport participation? So that's our number three, our ultimate goal in this wheel. We do that by taking a step back in the cycle and making sure that we're creating quality sport experiences. These are feeling states that involve satisfaction and enjoyment, and they're based on athletes' appraisals of whether the sport experiences satisfy one or more of their own values and needs. And these values and needs are the 6 aspects of quality participation, or what we call here in the framework, the building blocks of quality participation. And emphasize that you can't have the building blocks unless you first have a safe, welcoming, and inclusive environment. For instance, parasport participants need to feel safe, welcome, and included before they can open themselves up to experiencing things like challenge and mastery or any of the other building blocks. We've heard that loud and clear from our sport participants. Now, with the athlete at the center of the model, and with that good environment in place, coaches and programmers can take action to foster the 6 building blocks, leading to a positive quality sport experience. And over time, repeated quality experiences can lead to an overall sense of quality participation. So how do coaches, leaders, parents, and programmers support the building blocks? The CDPP Sport and Exercise team has produced numerous resources for use with children, youth, and adults in sport and exercise settings, for people with different types of disabilities. And these resources give very specific guidance on how to build quality participation in sport. These resources are free and they're downloadable from our website, cdpp.ca. How to do this that's another topic that warrants at least a full webinar. And I actually encourage you to reach out to Amy Latimer-Chung about speaking to you about this, but I'll try to do it justice in the next slide, just to give you a bit of a snapshot of some of the strategies that are outlined in these documents. So this slide gives strategies, or just a few strategies that are recommended for each of the building blocks. I'll just highlight 1 or 2 for each of the 6 building blocks. So under autonomy, strategies include providing instruction that supports a sense of independence among the athletes, providing the athletes with choices and options around what to do during training, during practices, during activities, and so on. For belongingness, building group cohesion and team atmosphere and creating personal connections. Challenge can be fostered by adapting activities to the athlete's level, creating personalized activities appropriate for that individual athlete. Engagement can be fostered by creating a consistent and encouraging program and creating personalized activities. Mastery can be fostered by creating environments that promote success and adapting activities to the athlete's level. And examples of ways to create meaning include creating personal connections between athletes and promoting and monitoring goal setting. If you're looking to get started on fostering more positive quality participation experiences in your program, I encourage you to check out our Quality Participation Quick Guide 2. This slide here just has some snapshots of the pages in that quick guide. What I like about this, so Amy Latimer-Chung and her team developed this. It's developed as an audit tool that lets you assess what strategies you might already be using in your program, and what strategies you could use to enhance the building blocks. So you might notice there's lots of check marks. Those check marks indicate if you use that strategy, those are all the building blocks that you're going to foster with that one single strategy. It's also important to note that you don't need to focus on all of the building blocks at once. For example, you might have a program that has a heavy mandate to create a sense of belongingness and social connectedness, and not so much a focus on mastering new sports skills. In that case, you don't need to focus on the mastery building block. You can focus on the blocks that are most relevant. You might also focus on different building blocks at different time points in your program or for different groups of participants. We have also developed and validated a 12-item questionnaire to assess participants' perceptions of the building blocks and the quality of their participation. We deliberately developed this to be a relatively short questionnaire, so it can be used in community settings and in programs as a way to track changes in participants' perceptions. And this is also freely available on our website. I'm just completing some analyses on some preliminary cross-sectional data using that quality participation measure. So this is a study involving nearly 600 Canadian adults with disabilities. They completed the measure, the quality participation measure, and other measures of well-being. In our Canadian adult sport participants with physical disabilities, we see that greater perceptions of quality sport participation is associated with a greater sense of emotional well-being and more positive life satisfaction. And among the exercisers with disabilities, similarly, greater perceptions of quality exercise participation experiences are associated with better emotional well-being, social well-being, and more positive life satisfaction compared to people who don't report such strong quality participation experiences. I think these data speak to the value of promoting quality physical activity participation in order to get these positive psychosocial outcomes that we all want and hope people will glean from physical activity. I also think that as we continue this work, we might start to see that the time spent on activity and the person's level of performance is not as important to these psychosocial outcomes as the quality of the participation experiences. So just as I wrap up this talk, at least this part on quality of participation, I want to emphasize 3 key points. The first is that it takes repeated and sustained quality experiences in order to create a lasting quality participation. The second is that the importance of each building block depends on the person and the context. Not everyone places value on the same elements, and the value placed could even change over time and according to the sports situation. For instance, the 2 sport activities I like to do are running and kayaking, and I run for the sense of mastery and challenge, but I kayak for the sense of engagement. We also think that the elements can change over time, that someone might start out, might join a sport program because they value belongingness and that aspect of sport. But as they get more involved, you might find that the personal experiences of challenge and mastery become more important. And thirdly, as I mentioned, it's not necessary to focus on building all of the blocks. Focus on the ones that are most meaningful to your program and to your athletes. And finally, just a few recommendations for designing interventions to increase physical activity. First of all, I can't emphasize enough the importance of engaging the end users, the people who will deliver and receive the intervention, to ensure you've taken into account their values, their needs, and their preferences. The buy-in and the fidelity to the intervention will be that much better if you take time to meaningfully engage these groups throughout the development process. We've also seen that theory and evidence-based interventions are far more effective than atheoretical interventions. Physical activity behavior change science is evolving at a remarkable pace right now and producing solid evidence on the most effective behavior change techniques. There's no longer any excuse for developing atheoretical interventions and choosing intervention components that don't have solid evidence. And finally, when designing interventions, think about participation in terms of both quantity and quality. There's no point in building programs with huge numbers of participants if those participants aren't having positive experiences that lead to positive outcomes in their well-being. And with that, I would like to acknowledge the tremendous group of students, colleagues, community partners who make this work possible. That's a picture of my amazing SA Action Canada lab on the right there, all socially distanced, and we sure can't wait to get together real soon for a brand new group picture. And if you'd like to contact me, there's my contact information. Thank you very much for your interest and for your attention today.
Amazing. Thank you so much for such a great talk, Dr. Martin Ginis. I'll open the floor up now to anyone who'd like to ask some questions. We've got some time. You're welcome to put the question in the chat or use the raise hand function and speak out. I can kick us off here with one. One question that I had when you were speaking about the different ways to implement interventions and stuff. One thing we hear a lot between from the medical community and from the community partners is there's this disconnect between the community and the clinical. Do you have any ideas or from your research, anything that says on how we can try and improve that continuum to improve the use of these guidelines and things?
Oh, that's a great question. Yeah, the answer is that it's not easy. What we're doing right now in Vancouver and GF Strong is we've created a partnership between the physiotherapists who work in GF Strong, the rehab therapists, and with Spinal Cord Injury BC. And it took a long time to do this, but we now have this relatively seamless handoff process whereby when the patient is discharged from GF Strong, the physiotherapist has given them a prescription for exercise, and they are then funneled to Spinal Cord Injury BC, who picks up where the physiotherapist left off to continue giving counseling and support specifically around physical activity. They have that proactive SCI intervention toolkit, and from there they know how to link that individual to other resources in the community. So what we're using is SCIBC as a bit of a conduit or a funnel to help that person transition to the community and then reach out to a wider set of resources. And I think that's a model that could be used in other sectors with people with other types of disabilities.
That is a fantastic partnership you've created there.
Hi guys, I'm sorry I was late. May I jump in here?
Yeah, of course.
So that was such a great talk and just so timely. Thank you for inviting me. My name's Candice. I'm a physiotherapist at the Alberta Children's Hospital, and we are embarking on a resistance training intervention for youth from 7 to 17. So it's just so nice to get these tools as we're in the development stages. So I'm going to be definitely looking them up. And in my view, us seeing the children at the Children's Hospital and then with the Calgary Adaptive Hub fully on board, that is, in my view, a very similar pipeline for continuing activity. So I think that's really beautiful. And I had one other quick question just with regards to, as I'm just like I've done a little bit of research, and for your intervention, did you have your control, was it a control without a standard of care at all? They were just awaiting intervention, or did you have them receiving kind of traditional standard of care versus your behavioral change intervention?
Yeah, it was just wait list. So we told them just keep on doing what you're doing, and in 8 weeks you'll get the intervention.
Yeah, because it would be curious to compare standard of care, what elements in standard of care would, like how those outcome measures would be, how they would rate on those similar outcome measures. Because as you had mentioned earlier, I mean, physical therapists are, to varying degrees using various techniques, in their interventions, right? But it's really great for you to really unpack the black box of what works, right? That's a gold mine.
Yeah, thank you for that. Actually, maybe I should clarify. In that study, our participants were community dwelling, so they weren't inpatients, and so none of them were currently with working with physiotherapists. But I think I know what you mean. If we made the standard of care working with physiotherapists, that would be interesting to see. But thank you very much for your comments.
Can I ask a question as well, please? Thank you.
Sure.
That's very, very impressive and very interesting research. Thank you for your talk. I was wondering, I don't know if I missed it, but in terms of the resources you've shown, I mean, you have an amazing big team, and I was wondering, with, for example, the interventions that you've done, if we were to do something similar, can you give some advice or ideas on how many resources you'd need in terms of persons, especially if you go to the individualized programs? I can imagine if you have all these interviews with every person, that takes up a lot of time. And yeah.
Do you mean the behavior change intervention or the quality participation?
The behavior change intervention. Yeah.
Yeah, that's a great question. So we achieved those outcomes with just 15 minutes of counseling per week per participant. So frankly, it wasn't a huge investment of time. And we did do a feasibility assessment with the physiotherapist who felt that they could do that feasibly, at least in that context. So we haven't done a cost effectiveness analysis, but I think given the minimal amount of time that it actually takes to deliver this, that it probably would show to be quite cost effective. I think as time goes on with behavioral science as well, we're starting to key in on what the key ingredients are and minimizing the amount of information and really key into what we need to give people. I remember 10 years ago, I was doing telephone-based physical activity counseling, and we would give people reams of information, and the amount has become that much more streamlined because we just know so much better now what works. So I know I'm not giving you a definitive answer other than to say that even on our telephone-based physical activity counseling program, which we've been running during COVID, many of those calls are just a couple of minutes long. People tell us mostly that they want someone to be accountable for, that knowing someone is checking in with them every week to see what they did, that is hugely motivating and helps them self-regulate and stay on track. So I think it probably could be done quite effectively and in quite a minimal amount of time.
Wonderful. Thank you very much. That's helpful.
David, go ahead.
Thank you. Well, before I give my formal thanks to you, Dr. Martin Ginis, I do have a question. Did the World Health Organization ever follow up with you as to your criticisms of their guidelines as it related to activity levels for persons with disabilities?
So in fairness, they sent out a draft. I remember doing it during COVID at my dining room table. So maybe March last year, they sent out a draft, and Amy Latimer-Chung and I provided extensive feedback, and they did change some things. For example, the draft we saw had children, adolescents, and adults all collapsed into one guideline for people with disabilities. And we said, please do not consider adults and children the same in a guideline. So they did change that. There were a couple of things they changed, but ultimately, no, the premise is still the same. It's all based on evidence from the general population. We wrote a commentary on it, and they commented back. But yeah, I still have that fight to keep fighting.
Well, and I don't think that's a unique circumstance where an organization has used guidelines and general rules of thumb for an able-bodied population, then just extrapolated it onto a disability population. I would guess that that's not a unique example.
I can't find another example, but it could be. At the end of the day, it really boils down to philosophy, that I believe that guidelines should be evidence-based, based on the evidence of people who are actually going to use them. And there's some people who philosophically disagree with that guidelines are generalizable, full stop. So, it really falls, I think that boils down to where you fall in that philosophical debate. And that's something I consistently see the value of engaging with the people who are going to take up the research evidence. And I can't get my head around the idea of not doing that, but I know that others disagree. And
the more time I spend with Dr. Carolyn Emery, the more I agree with that, and the more I am convinced of that as well. And hopefully, the Calgary Adapted Hub powered by Jumpstart can follow the lead that you've presented to us with the CDPP for doing exactly that. So on behalf of Carolyn and myself and the executive team and the board and the advisory committee and the entire Calgary Adapted Hub powered by Jumpstart, thank you for joining us today. I've been following your career since when you were at McMaster, and I've always been impressed with your ability to, tie in the practice and the theory and to translate, knowledge for the practitioner. Again, it's certainly something I've aspired to do in my own career. And so thank you for joining us today. I'll turn it back to Eliza and Karen just to wrap it up and to talk a little bit about our next speaker, who is a former student of yours and someone that you made reference to in some of your studies. So I'll pass it back to Eliza and Karen.
Terrific.
Hello. So again, thank you for speaking today and sharing your wisdom with us. Is very, very interesting. Just to do a little plug for our next seminar, and I'll put the flyer in the chat in just a moment, but we have, sorry if I mess up this last name, it's a hard one, Dr. Kelly Arbor Nicolatopoulos speaking about quality play in children and youth with disabilities. Is it a right or a privilege? So I'm sure that will be very interesting, and that's coming up on June 24th. And then Karen, I'll pass it over to you with an exciting announcement from us.
Yes, this is a sneak peek exclusive announcement for those folks who have stuck around to the end here. So we will be officially launching tomorrow. Our website is live, so you can now go check it out. So we'll be putting that out in the news tomorrow to share with the folks of Calgary and beyond. We really hope that this will serve as a tool for families to connect with us and help overcome some barriers to participation, and that we can help be pathfinders through our partners to some meaningful opportunities for participation through the Calgary Adapted Hub. So exciting news. So please, it's live now. Feel free to go check it out. But we will be officially launching tomorrow.
So with that, that concludes our session. Thank you again so much, Kathleen, for joining us. It was great to see you. I'm still a little jealous about the map that you presented right at the very front end about your walk to campus, I think, more than anything else. It was great to see you. Thank you again. Good night to everybody, and thank you to everyone who attended for joining us. Go check out our website, and we look forward to seeing you again in late June when Kelly joins us from the University of Toronto. Take care.
Thanks so much, Kathleen.